We'll make a start then. So thank you for joining us this evening. We're here tonight with Mr. Charles Evans, who's going to talk to us about rectal bleeding, FIT, and the colorectal 2-week wait pathway. If I could just ask you to move the slides on, please, Mr. Evans. Okay, so session will be starting shortly. Same rules as usual. If you can make sure all your devices are muted and cameras, if they can be switched off for now. If you have any questions, then you're very welcome to ask them as we go along, or type them into the comments section, and I'll ask Mr. Evans on your behalf. Like I say, you're not obliged to turn your camera on, and at this stage, it would be better if you could just keep the cameras off. But if you're asking any questions, then please feel free to come off to come onto camera. The session will be recorded this evening, and I'll send that out to everyone once I send out CPD certificates, which will be in the next few days. If I can just ask you to move on, please, Mr. Evans. Next event has been booked. I have sent out some emails, so hopefully you've received that and you've already booked your places on this event. We've got Dr. Anton Borg with us to talk about haematology. That's on the 15th of June, an evening lecture again at 7 p.m. Like I say, if you haven't already registered, just drop me an email and I will add you to the list. And next slide, please.
Right.
Okay, and as per usual, we'll be posting the survey link at the end of the presentation. So I'll just pop that in the comments section. If you can leave feedback for us, it'd be really helpful. It helps us to improve on these sessions, know what we're doing well, so forth. Like I said, CPD certificates will be sent towards the end of the week or beginning of next week. If you are logged on and you're logged on under someone else's name, can you just make sure you let us know who you are, so that we know who to send the CPD certificates out to. And I think that's everything from me. So if I can hand over to Mr. Evans. Thank you, Mr. Evans.
Thank you very much. So hello to everyone. Thank you for joining us on this quite nice, pleasant Wednesday evening. Sorry, you're stuck on a Teams meeting with me. Just so that those of you who don't know me, I'm Charlie. I'm a colorectal surgeon based at Coventry at UHTW. I've been there since 2014. I'm a colorectal surgeon, but my official title is head of gastrointestinal surgery. So I kind of have oversight over the slightly mad HUB and upper GI surgeons. But my main thing is colorectal, and in particular, where I've probably made a name for myself is doing robotic surgery. And I do robotic surgery in Coventry. I've been doing that for about 8 years, but also now do that across the country, teaching anyone who's starting doing robotics in the UK, but also go as far across Europe and even as far as South Africa. And I do deliver robotic surgery now privately, but that we have to do in London just due to access to robots. Or very soon there'll be a robot in Birmingham as well. But yeah, no. So I'm asked to talk to you all about basic rectal bleeding, and then I think topical is the change in the 2-week wait colorectal pathway and the introduction of FIT to symptomatic patients. And literally this morning, I've been on a big meeting in Coventry with our colorectal surgeons and our team about how this pathway is going to change for you guys. And we want to get the word out there about how the changes are. Hopefully you've heard a bit about it, and also the non-specific symptom sort of referral pathway. So I really want to talk to you about all of that as well, really. So please feel free at any point to put your hand up, ask me a question. I'm not sure I could talk for a whole hour on my own about rectal bleeding. I might kill myself. So let's all, if you can engage with me, that'd be great. And stop me at any point. We'll start on. So to kind of get it going, I will just give you 2 case presentations about rectal bleeding, something obviously primarily anorectal, and we can talk about the different pathology that we'll see with that, what you guys can do in the primary care, and then what also I potentially can offer in my clinic or any of my colleagues. And then once we've done all of that, I will talk a little bit about symptomatic rectal bleeding, the FIT pathway, and ultimately what tests you can do for that, just so you can, again, give your patients a little bit of a conversation about, what this journey is going to be if they do end up being referred to us. And finally, just a quick oversight of the major sort of colorectal pathologies at the end if we're running out of things to say, and I can talk to you a bit about those and if there's anything specifically you want to ask about, or patients you've had questions with, or something that you want to know about, that's, at the end we can kind of go through all of that. I'm aware that a lot of patients that you see have GI symptoms, and a lot of patients are quite distressed by them and find them embarrassing, but they are important and they do impact upon their quality of life. And the reassuring thing for you guys is that a lot of them are eminently treatable without the need for a surgery or even, major investigations. But the trouble is a lot of GI symptoms can be quite vague, quite nondescript, and we always worry, and there's repeated news about bowel cancer, and when we need to exclude sinister pathology. So it can be quite a mixed bag. It can be quite tricky. And, our job is to help you with that. It's still classic medicine. Whilst I'm a Mr. Robot surgeon. The thing that what I do is see my patients, take a history, and that history gives you, most of the time, we pretty much know what's going on from that history. I'll examine them, and I know that, obviously you can do the same. But we have the additional tools in clinic to some of you of a proctoscopy and a rigid sigmoidoscopy, and certainly we do that in all our clinics. They're all available, and from them we can arrange investigations and, primarily endoscopy, colonoscopies, sigmoidoscopies. But there's also some sort of quite high-tech radiological investigations, MRIs, ultrasound scans, and CT scans, and different types of CT scans that we use. And ultimately, if we're really struggling, we can always do an examination or an anaesthetic. And these will hopefully lead us to a diagnosis and then some potential options for treatments, which I'll talk to you about some of the more simple stuff in this talk. So as an easy starter, we'll start with a young patient who I saw in clinic the other week. Young man in his 30s who basically was complaining about some bright red blood that he noticed dripping in the pan. It was sort of blood that wasn't mixed in with the stools, kind of coating it, and it'd come and go. But he was distressed by it. It was affecting his quality of life. But when you delved into it, realistically, he didn't really have any other worrying symptoms at all. He had no change in his bowel habit. He was systemically well, and he had no past medical history of note. He was not on any medications that would sort of exacerbate bleeding, and there was no worrying family history of bowel cancer. So with that, just with these, fairly straightforward symptoms that seem very localized to the anorectal junction margin, primarily thinking about anorectal diseases, and the commonest being hemorrhoids, anal fissures. But don't, if there's anything else that goes on, I just to alarm you, I saw a 24-year-old chap at the Nuffield only a month ago who had got rectal cancer. It's a genetic thing, but he was the first one in his family to have it, but it's been proven. So even if you think it's a local anorectal bleeding and it's something straightforward like hemorrhoids, and you've seen hemorrhoids, if it persists or there's anything else, like this guy particularly had some mucousy discharge and some bloody wet farts, you must think about other causes as well. But realistically, the majority of these patients you're going to see, if they've got no worrying red flags, simple little bit of bleeding that comes and go, you're going to treat, you're going to assess them and treat them for some sort of anorectal disorder. And as I said, the commonest one is hemorrhoids. Now, I won't really diagnose that until I've at least had a look endoscopically. I will perform a proctoscopy in the clinic, which will allow me to see the anal cushions, which is where these dilated anal cushions are hemorrhoids. And to make sure I'm not missing any other pathology, even in a 34-year-old, I personally would refer them on for a flexible sigmoidoscopy. But once you've confirmed that they've got hemorrhoids, you've got a rather confusing array of options in terms of treatments. Primarily, the key thing is to give them dietary and toiletry advice. You want them to avoid straining. You want them to not spend hours sitting on the toilet playing with their phone if they're men, locked away. And if they're women, obviously some of them can have difficulties with defecation if they've had children or pelvic floor disorders. But you want to talk to them about their diet. You want to make sure that they've got good volumes of soluble fiber rather than insoluble fiber. And what we mean by that is sort of avoiding sort of, well, you can have insoluble fiber, but whole wheat and whole grain, I'd rather recommend instead you take things like oats, bran, nuts and seeds, because they not only do they sort of help soften the stool and encourage it to flow through, which again, which is good for hemorrhoids. You don't want a firm, bulky stool pass because that can just aggravate them. I know a lot of you will have recommended suppositories, Anusol, and all these sorts of different types of various hemorrhoid treatments you can get through the pharmacy. And they're mostly sort of low dose hydrocortisone sort of creams, which help with irritation, and often are quite a good sort of placebo. But the reality is they don't really do anything majorly helpful. And whilst if they make the patient feel better, I personally don't specifically prescribe my patients Anusol creams, and usually tell them if they've got irritation to leave it alone, because almost those things cause more irritation. So it's dietary and toiletry advice. And then when I mean toiletry advice, I sort of explain, please, when you're going to go to the toilet, wait till you really need to go, and then just go quick to the toilet, do your business, and then go. Don't spend hours on the toilet. If you want to sit and lock yourself away, go and lock yourself away somewhere else. And usually these things are enough to get people through sort of their symptoms to the point they're manageable. If that doesn't work, people often get referred to us and say, "Oh, I've had a banding in the past or an injection." And what used to happen is people often used to be injected with phenol, a low dose phenol, and that would sort of sclerose up the blood vessels that supply the hemorrhoids. That's kind of gone out of vogue because it's quite difficult, and everyone worries about giving the wrong dose of phenol and obliterating the anal canal. Whereas banding is quite effective, but really it's only effective if you're doing it under general anaesthetic. So people have stopped doing it in clinics because occasionally people band the patient too low and then they're in agony, and it's like literally an emergency rush around to theatres. Or there have been cases where patients have been banded in the clinic, gone out and suddenly passed a gush of blood. And even I've had a patient, not done by myself, but when I was training in Frimley Park, where he ended up crushing his claw. He was so distressed with all his bleeding. So really, office treatments aren't done that frequently anymore. You may well have heard of, or patients will come to you asking about a thing called the Raffaello procedure, which is an ablation one where basically you sort of coagulate the hemorrhoidal arteries by putting a probe at the bottom. And and it's becoming more popular, and it's certainly sort of one of the buzzword hemorrhoidal treatments. However, in all honesty, I think it's only really useful for very sort of mildly symptomatic hemorrhoids. And at the current evidence through NICE is that you shouldn't be doing it unless it's part of a trial or it's part of an audited process. And that doesn't happen in the private sector, or even, and certainly we don't offer Raffaello at Coventry Hospital. And until there's real proof it works. Oh, hello. I wouldn't be. I don't personally advocate it. The procedure of choice that I try and recommend as a sort of the least minimally invasive one is the hemorrhoidal artery ligation, the halo procedure. And on the bottom right hand corner, you can see a sort of a probe up someone's bottom, and that's a proctoscope with a little Doppler probe, if you can see there. And that allows us, when a patient's asleep, to identify the hemorrhoidal arteries. So I basically work my way in a clock around the bottom hole, find the arteries, and then tie those off with a stitch inside. And that shrinks down the hemorrhoids, and it's really good for bleeding. And the other thing you do is you can then sort of open up the proctoscope so that the prolapsing tissue can be plicated up. So any prolapse as well as bleeding is treated in one go. And it's a very effective, relatively painless procedure. Occasionally, if you put the stitch too low, that can be quite uncomfortable. And if you have patients who've got a significant prolapse and don't want a formal hemorrhoidectomy, I will do a halo procedure, and then they will slightly find that more uncomfortable. But generally, it's a well-recognised, good procedure for hemorrhoids, and it's certainly something I offer both in the NHS and at the Nuffield. If you've got bigger hemorrhoids that are falling out, they used to do a thing called a Saport hemorrhoidopexy. I wouldn't worry about that. But the gold standard, if you've got really horrible hemorrhoids, is a hemorrhoidectomy. And if you see someone in your DP practice where there are these big, enormous things coming out of you when you look, they almost certainly will need a hemorrhoidectomy. And whilst it has a very bad reputation for being an agonizing procedure, they talk about pooing glass. Actually, it's a really good procedure, and a lot of patients don't find it too uncomfortable. Those that do, usually after about a 4-week period, are much better. And by the time I see them in clinic at 6 weeks, they're very, very happy. I avoid seeing them at 2 weeks because I'm slightly worried they might want to lamp me. But I send them home with lots of laxatives, and it is a good procedure. And as long as it's done by a colorectal surgeon who won't damage the anal sphincters or cause an anal stenosis, which is not good, and you can really cause damage if you do it wrong, it's certainly something I'd advocate if I'm not giving them a halo. And so it's either if they've got big external things or big skin tags they want to remove as well, I would tell them that you really need a hemorrhoidectomy. Whereas if it's bleeding and internal hemorrhoids that are dropping down, I do a halo procedure. Everybody clear about hemorrhoids? I've spoken for about 15 minutes. The next most common cause for bleeding that we see is an anal fissure. And actually, these are surprisingly common. Quite a lot of your patients will have them. They're often seen in young patients, equally seen in men and females. But what usually they notice is they do get the bleeding and it's bright red blood, but they also get some basic excruciating pain on defecation. And it's basically every time I go for a poo, it's awful for about an hour or two afterwards, and I get blood. And then you're like, well, that's probably going to be an anal fissure. Why they get a fissure? If you imagine the anus as a clock, the blood supply comes in at the 3 and 9 o'clock position, and you classically get them either anteriorly or posteriorly. The majority are posterior, and it's to do with the blood supply kind of making it not as far around. And it's a bit like I try to explain it like a cracklet. Every time it opens, it breaks the heel and breaks the wound, and it's not healing. So, and once you've had symptoms for after 6 weeks, they classify it as chronic. It doesn't really matter. But if you've got a patient who's got acute symptoms of this, it's relatively short-lived, they've suddenly got pain and bleeding, you should be able to manage it in the community by making them avoid constipation, putting them on some laxatives, and just reassuring them. Toiletry and dietary advice, a bit like hemorrhoids, again, is the key, making sure that they're not passing hard stool, and usually that's enough. If that doesn't work, then you can prescribe them topical creams, and I know a lot of GPs do that. There are two ones. There's GTN ointment or diltiazem cream. The GTN ointment is liked by practitioners because it's cheaper. The problem with it is that it often gives patients a headache and is frequently not tolerated. The diltiazem one is the one that surgeons like in hospitals because we don't have to worry about the price of our drugs, and it has probably equally effective or slightly more effective because it's slightly better, well tolerated, although you have to warn them that it can be quite sore when you put the cream on. But I usually prescribe it for a 6 weeks course, giving it twice a day. And of the patients that get as far as seeing me in clinic, 2/3 of those, their fissures will heal just with the topical cream. I would then usually arrange a flexible sigmoidoscopy. I don't do that until their symptoms are better because it's usually agonizing to sort of arrange an endoscopy. That leaves you with a third who still haven't healed, and they're the ones who then I will basically recommend that we do a Botox injection. So you've got 2 rings of anal sphincters, an internal ring and an external ring, and we inject Botox in the intersphincteric plane, which is basically the gap between the internal and the external ones. And what we do, you can just about see it there. We inject at the that's the 9 o'clock and the 3 o'clock positions. So we paralyze the sphincters away from where the fissures are, and that basically paralyzes the internal sphincter, relaxes it, and it gives basically the fissure a chance to heal. And that is effective in a lot of patients. It probably, of the third that haven't healed with the creams, 2/3 of those will then heal with the Botox, and if that doesn't heal, another Botox, and it works. It's relatively safe. The only real risk of sort of infection if you inject in the wrong place, and you have to warn them for the 6 weeks. They may, with the paralysis of the internal sphincter, have sort of, I describe it as inadvertent passage of flatus and maybe occasionally a bit of leakage, but usually they actually tolerate it quite well, particularly as they've often got quite tight sphincters at the time of the fact that they've got the fissures in the first place. Everybody happy with that fissure treatment? So that's primarily anorectal things. As long as you've ruled out malignant stuff, if proctitis or anything like that, you're going to be treating hemorrhoids, fissures, or skin tags. It's all relatively something proctology based. Occasionally, it could be an abscess that might need drainage and fissures, but fistulas. But again, you should have more than just bleeding symptoms. You should have pain and discharge. The other classic one, and this is another lady I actually saw this week in clinic, is a sort of a slightly more elderly lady. Well, not really elderly, but so in their 60s. But when the blood is not just anorectal, when it's bright blood but mixed in with the stools, or if there's anything else associated with mucus or a change in their bowel habit with increased stool frequency or constipation, vague abdominal symptoms at all, immediately you're starting to think red flags. We need to investigate further. I'm always in clinic wanting to know about their past medical history. Often patients seem to forget they've had bowel operations in the past, even though they're a major deal. They may well have been put on anticoagulation medications, and again, that will often, some patients who will have never noticed any bleeding from a small polyp, suddenly with just the starting of some anticoagulants, will suddenly have sort of more symptomatic bleeds, or they'll be more frequent and more obvious. There's no doubt it's important to know about a family history of bowel cancer, and just some general social history, knowing about smoking, drinking, and their well-being is important, because it's going to affect assessments, and where how you're going to assess them, and where you're going to assess them, and what tests you're going to do, because that's once they've come to be in clinic at the 2-week weight clinic, what ultimately we're going to end up assessing them, and it's knowing which is the right test for them. Hello, can lidocaine gel be used for anal fissure pain, or is the let me just open that. So is the I worry about systemic absorption and not too frequently used. I personally, if they're in agonizing pain, will give them lignocaine gel just to kind of break the cycle. I don't think you can overdose yourself on lignocaine gel just from the bottom end. And usually, because we'll give them the sort of the instiller gels that you get for giving catheters, I give them with like 3, so they can't really go overboard, and I think it's just enough to break the cycle. Other things that are quite helpful are a bag of peas, or filling up a plastic glove with water and putting it in the freezer, and then you've got a finger-shaped thing that can go up there. There's Jonathan's asking a question. Hello, what's your, do you want to...
I'm not. Sorry, I missed the start of the meeting, so I'm not sure the rules.
That's all right.
You're allowed to come off camera or not.
No, come on camera, talk to me. It's me on my own is depressing.
I was going to say, presenting to a blank screen is quite challenging, isn't it? John Menon, GP in rugby, thank you so much. Some really interesting things, asking people if they flick through their phone on a toilet. Great question that I'll start using a lot more. A question about proctalgia fugax.
Yes.
It's sometimes really difficult, I think, as a GP to treat this. And I've got a few people who it's quite debilitating. So any tips or tricks would be much appreciated.
So it is a tricky one, because you guys don't have. See, I have the ability, when I have someone who ends up with me shooting anal pains, I get the benefit of being able to send them off for a flexible sigmoidoscopy and an MRI scan and saying it's all normal. And once they know it's normal, often it goes. So I think it's the reassurance. And I've been when I was an RSO at St Mark's tertiary referral, we ended up getting tricked, like literally being seen through everyone, and it was just proctalgia. It's just it's not easy. I think you have to make sure that the description of the pain is such that it's kind of shooting pains at night just comes on, and be confident in the diagnosis, which kind of helps reassure them. If they've got no other worrying symptoms at all, and it's just literally these shooting pains, again, getting them to work on their bowels, because I think a lot of them are constipated, and actually it's fecal loading in the rectum that's causing the discomfort. So again, really honing in on that and making them work on dietary and lifestyle stuff, and giving them some sort of direction whereby they feel like they're taking control of the situation rather than just being this other thing. And often, I think once they've got their bowels more regular, even though I know some patients you end up giving them amitriptyline and all sorts of different things to try and help, actually it's their bowels and the function that needs sorting out, combined with what's going on with their mental health and all those other things. So it's actually more of a holistic approach. But I do accept some people are completely normal healthy suddenly start getting shooting pains up their bum. And if you're not sure and it's not really resolving, then basically I would probably recommend you come and see a GP. Sorry, not GP. You're the GP. See a colorectal surgeon. I mean, I did notice someone asked about what were the laxative I use. So I'm a massive fan of Movicol. laxatives, because I think they do both. They stimulate the bowel and soften the stool. And again, for even with patients with proctalgia fuga, I would sort of, if they may not really be aware of their bowels, whether or not they have got quite firm stools, or just to change their bowel habit and soften out might make things easier and pass through. So yeah, I wouldn't hesitate. And the Movicol is a very safe drug, sort of like it's absolutely fine for them to use that.
Thanks.
Okay, cool. So now we're going to talk about fit, and this is where I'm slightly worried that you might all want to jump on me and kill me, because there's now going to be a change in the 2-week weight pathway. I'm going to talk about fit, and for those of you, well, I'm sure pretty much everyone's heard of fit now, why it's been introduced, and then go from where there. Now, obviously, it is a test that measures human globin in stool. And what's good about it compared to the old FOB, it's not just a black and white yes or no, reliant on 3 out of 6 positive dips of a stool thing. It actually gives you a figure, a measure, and so you can determine what you class as a positive test. And what's been happening for the bowel screening program now for some years is that if a fit test was over 120, so quite relatively high, that was deemed suitably high enough that the risk of having a polyp, at the least a polyp or maybe a cancer, was high enough that it deemed, even if you're asymptomatic, eligible for you to have a colonoscopy. And that's pathway is working really well in Coventry. We've got a great, and Warwickshire and George Eliot, a great surveillance, screening program. And what the fit does, why it was, as opposed to being more specific and sensitive with a better accuracy rate, is it's a better tolerated test, and it's a better tolerated test in those groups of patients who actually are usually the ones we want to know about, those who participate in less frequently, men, people of ethnic minorities, and the lower socioeconomic groups, and they're classically the ones who are more likely to have a bowel cancer. So it's and this is I've talked about fit tests and screening for quite a few years now, 5 years, but it was the hot topic about screening. But we've now moved on to sort of using it with symptomatic patients. And again, at Coventry, we did some studies where we screened patients with fit tests and urine VOCs, and got very excited pre-COVID about the idea of fit being introduced. But basically, there were caveats to it, and it was quite difficult to sort of kind of get a consensus on it. Then COVID happened, and then everyone had a nightmare in terms of access. Delivery of colonoscopies became really difficult, and so people reinvested into this sort of looking at the fit test and symptomatic patients. And there were a lot of studies beginning to happen that got really pushed through. And this is the best UK one, the NICE Fit study. It basically involved 10,000 patients who were just 2-week weight patients, and they all got a fit test, and then they just looked at the outcomes. And and it's interesting. So patients presented with rectal bleeding, still 56% of them had a negative fit test. So so that's interesting in itself. But when you look into those with a negative fit test, even with rectal bleeding, 99.9% of them didn't have a cancer. So you're really unlikely to have bowel cancer if you've got a negative fit test. And basically, again, with what they showed was that if you use the fit test and then use a sigmoidoscopy alone for those with a negative test with bright rectal bleeding, you'll only miss a minuscule amount of cancers. So actually, it's a really good test. It's a safe test, and it's a better way of allowing us to triage the limited resources we have. And whilst endoscopy is being expanded, and at Coventry we're opening up a bigger unit over at the Rugby site, and we're always employing more endoscopists, and actually we've pretty much managed to get back on our backlogs. We still have an over dependence on colonoscopies, and it's a difficulty delivering it. And it's not least of all, it's not very nice for patients, and it's a high risk. And often you guys are in a dilemma as to whether or not to refer these patients on. So at the end of, halfway through last year, the BSG, the British Society of Gastroenterologists, and the ACP GBI, Association of Coloproctologists, did a combined update, and they've recommended that we change our pathway using a fast track pathway for 2-week weight patients, whereby before patients are referred to us, if they've got symptomatic, or they're suspected of a colorectal cancer diagnosis, they will do a fit test in the community. There we go. How is fit negative in rectal bleeding when it's detecting? Reply. So that is because you might get rectal bleeding that's anorectal bleeding, so it's kind of detecting it within the stool rather than coating it. And also, similarly, though, there are those who get a false positive because of the hemorrhoids. And I guess it's also to do with well, it's measuring the globin level of the blood from within the colon itself, the lumen, I think is the answer. I'm not very. I'll deviate on that one. But ultimately, so anyone with a fit, okay, that's right. In primary care, if you have a positive fit test, and now with what they class now as a positive fit test is much lower than the one for screening, so only a greater than 10 micrograms of hemoglobin, so a much smaller layer, that can be now passed directly onto the 2-week wait colorectal cancer pathway, hopefully most of them through a straight to test. So again, shortening the time from presentation to diagnosis. But if it's well, FEOB, yes, FEOB is being phased out. It's basically purely fit now, really. And hopefully you will be getting access. And again, I'll talk about this because I'm going to show you in a minute a slide that's specific to the southwest Coventry. If they've got, obviously, it's not foolproof. You still need to assess your patients, and if they've got ongoing symptoms, they should be still referred on. Just the pathways are slightly changing. And I'm going to show you this slide here. So this is literally, oh, hello.
You see private patients, huh?
No. We often get a fit back saying may have been referred. That was, sorry, I can't. What was that say? May have been referred directly on the 2-week pathway. Do all positive fit tests come to you guys? So the plan with that is that not to us as surgeons, but to we have a sort of a nurse. Well, basically, all tests go to a central lab, and then those positive fit tests will come to us, and we will that will be streamlined through. And if you look at this path, this is basically the pathway that we kind of we basically what we're going to do, so that anyone who has a fit, basically anyone who attends the GP with concerned about the lower GI cancer, ideally will have a fit test. Now, clearly, those who are unable to do it, and we have to go down a different route, we will then they will have the fit test. If it comes back as positive, then they will be fast tracked down our 2-week wait pathway, and then they'll be assessed by a nurse specialist who, if it is deemed that they're fit enough, they'll go straight for a colonoscopy. If not, and I mean, if they're not, then we'll see them in clinic and decide what is the right test, probably a CT colonoscopy. If they're fit negative, as you can see, there are various things, but those patients don't go down the 2-week wait pathway or go back to the GP practice. If you're reassured and things are fine, they can be an advice and guidance or a routine referral. If they do have iron deficiency anemia, then they should then be back down the lower GI pathway, and we'll arrange ideally for an OGD and a colonoscopy, pending fitness for that. If they've got ongoing symptoms, even though they've got a negative fit test, we have the NSS referral mode, which is this non-specific symptom pathway, and I'll show you the referral pathway, well, sort of referral guideline for this. If they have if they've got basically bright red rectal bleeding, even with a negative fit test, and you're concerned, they need referral for a flexible sigmoidoscopy, and that should be basically at the moment. So the plan will be for there to be a sort of straight in to have a flexible sigmoidoscopy pathway. That's not yet there. So if a patient has a negative fit test, i.e. less than 4, it is negative. Yes, correct. So anything under 10 counts as negative, and in the part, so that is rule. They basically, as far as we're concerned, they do not need to now go under the 2-week wait pathway unless they have other things such as an unexplained abdominal mass, rectal pain, and or ulceration. So yes, so hopefully the fit turnaround time is shorter. The limiting steps of this are, one, access to you guys to get the fit test. At the moment, you guys have to request the fit test. That gets sent out centrally. Then we rely on the patients to do it and send it back. Now, I think, you know, the point I made at our meeting today was like, it needs to be as easy for you guys as possible doing a fit test. And I think if there's a way whereby you can just hand them a fit test with getting access straight away, that would work. But like, that is not as straightforward as it sounds, because obviously you've got to be able to monitor those tests and work it all out. So there's going to be work on that as well. But I think in the big scheme of the pathway, that turnaround time isn't so massive that it affects outcomes, and realistically, we need to improve that pathway so it isn't delayed, it isn't slow. But yes, so if they've got concerning, you know, other symptoms such as a mass, rectal bleeding, even if a patient has iron deficiency here but negative, they should still be referred. Yes, they should still be referred at the moment for a colonoscopy, and we would also arrange a gastroscopy. Sometime, like if they're negative at that point, we would then discharge them. But there are other things that can be done. Like, a lot of my colleagues would like to do a CT scan, make sure they're not missing anything else. I personally would recommend repeating the bloods, and if there's still persisting anemia, referring on to hematologist. There is also things checking for renal function, things like that, which should have been done in the blood test in the beginning. But yes, a negative fit test with iron deficiency anemia still, at the moment, we would still, because of the pickup rate of cancers with those, we'd still rather endoscope those at the very, or at least assess them to see whether or not we can endoscope them. There is a group when the patient doesn't do the fit test, like either we had a woman who kept dipping the whole box in the stool or filling it with urine. Those are sort of things where it becomes more challenging, and if they're failing to do the test but need assessment, then they should, it's sort of been deemed, they should then be referred directly to the hospital, either down the non-specific symptom route if they haven't got symptoms, or just refer them onto the 2-week wait pathway at the moment. That would be my recommendation. So yes, and these are basically, if they're fit positive, the forms aren't out there yet, but these are the ones, generic ones, that we would which have if with a positive fit test with the symptoms, you just tick it and straight in. If they've got a negative fit test with rectal bleeding, send them in like this. And this, so I only just seen this. This is the non-specific symptom cancer pathway. It's still a 2-week wait cancer pathway, and it's for those patients with sort of vague symptoms that kind of mix in with GI symptoms, like, you know, unexplained weight loss, continuing sort of loss of appetite, nausea, vomiting, bloating, and they will still be filtered down an urgent pathway, but that's run by the physicians now rather than the colorectal surgeons. And as you saw on that sort of pathway before, there is, in the new sort of GI way, that some of these patients will end up on that non-specific referral pathway. So it's quite changes. Correct me if I'm wrong. It's not available. So it's not yet available. This is sort of Coventry, and at the and again, all of this is all in evolution, because South Warwickshire haven't fully signed up to even the beginning bits. They want to sort of clarify. We are definitely introducing this part of it, but South Warwickshire, I think, want to have, they've got slightly easier access to their 2-week wait clinics and their colonoscopy. So there's still debate about the finalisation of it, but certainly the national guidelines are as is in this slide, and it will be coming out just to sort of work out the resources. So a little bit, again, hopefully a lot of you are aware of this, but there are some quite new exciting tests as well. But so obviously the investigation of choice remains the colonoscopy. That's still the gold standard. And you've got about a highly sensitive, specific test with the benefits of also being able to treat patients if they've got things like small polyps. If they've got a cancer, we'll get a tissue diagnosis, and most patients, it's actually very well tolerated. We all have state-of-the-art kit now with scope guides, which we never used to have. So patients used to talk about being in agonizing pain and being put through an awful ordeal. And now we scope with much higher, much better colonoscopy equipment, and with these special, it's basically sat nav, and we've got that at the Nuffield as well. So again, there's no difference between that and the NHS hospitals, and it's a really good test, and it's safe, although it becomes less safe if you're doing therapeutic procedures, taking out big polyps and things like that. You probably have heard about CT colonography, which essentially is basically giving someone a CT scan, but at the same time having given them full bowel prep, giving them something to drink that's radiopaque, and then puffing some air up their bottom so that you get these beautiful images of the colon. And actually, they're a really good test for detecting lesions within the bowel. You can pick up lesions as small as 6 millimeters. The challenge with that is then deciding what we do about it. It's a really good test for those patients who had really difficult colonoscopies in the past with long looping sigmoids, who didn't tolerate it. They're patients who you don't need sedation for it. And they're also quite good for patients who are sort of struggling with abdominal pains, or you're slightly worried about other symptoms, vague symptoms. So you get to see a bit of a bigger picture about the rest of the abdomen and pelvis. If we have a patient where we can't complete a colonoscopy on, we'll do a CT colon. But the CT colon does still involve the patient taking full bowel prep. So we have other ones like a CT minimal prep, whereby the patient will just drink the contrast and not have the bowel prep, and that's quite good. It will pick up big bowel lesions, but might miss smaller polyps. So we've got even in CT, there's a whole range of sort of extremities, and even if they can't even tolerate the bowel prep, we can just do a plain CT. But that's the least good one. But the future is colon capsules, which we're now delivering that service at Coventry for some of our 2-week waits, and I'm sure it'll be coming across the whole of Warwickshire. And that essentially is great, because what you do is the patient's given a tablet, and once they swallow it, they can be at home, they can be anywhere, and that, unlike the sort of you might have heard of the small bowel capsules that look at all of the gut and take pictures of that. This only opens up and starts working once it's got into the colon, and you get really great accurate pictures all the way around the large bowel, which then need to be read. At the moment, they're read individually by clinicians, but with time and with AI, they'll be done super quick, and they'll pick up smaller stuff that then needs endoscopy if required. So again, that's potentially the future, and you may hear about that, and I'm sure the Nuffield will be looking to delivering that soon. That I mean, I've worked with gastroenterologists who do it privately, but as far as I'm aware, we're not yet doing it in the Nuffield. Has anybody got any questions about the 2-week wait pathway or anything that's kind of coming in, or the investigations? No? Good. I'm not going to lecture you about bowel cancer. I'm sure you've all heard it all before. The trouble is that if we pick it up early, we can really treat it. And if we don't pick it up early, it becomes very, very difficult to treat. That said, we now offer much more advanced treatments, not just so if a patient presents with liver metastasis or lung cancers, certainly at Coventry, we can offer them, we'll probably give them some chemotherapy first, and then potentially we will remove the liver lesions or the lung lesions. As you're aware, I'm a robotic surgeon, and I'll do all of my rectal cancer work robotically, and even now all our colonic work, and basically do that robotically as well. And the benefit of doing that is, when we kind of much more precise, and we've shown with our evidence at Coventry that our clinical outcomes are marginally better than laparoscopic. Well, how do outcomes compare? So let me just open that up. Between the UK and other similar GDP countries, well, overall they're still slightly worse, I would say. If you look at the national average, ours is probably, in the European average, it's slightly lower. But I think you'll find that will change, because there's been a massive expansion in robotic surgery in colorectal departments across the UK over the last sort of 24 months. And so Warwickshire's just got their robot, nearby Bedfordshire, all the trusts are getting them. And as I was going to say, sort of in our trust, we've shown our rectal cancer TME grade, so the quality of the specimen is better with the robot, and that's led to better clinical outcomes and survival outcome down the line. So I think the robot is helpful. I think a lot of it is about detection and presentation, and obviously early, participation in screening programs is really important. So encouraging your patients to do their FIT stool test when they're invited to do so, and then those who do have symptoms, getting them in early. And this is why we want to streamline the system, so we get the right people to see the right people early. We have access now to a much greater range of chemotherapy drugs. We now use not just standard chemotherapy, but they're immunomodulatory drugs. And actually, like I talked to you, I mentioned the 24-year-old, he's actually getting immunotherapy treatment, and the outcomes from that are really exciting, because if they have a certain types of cancers, the immunotherapy not only treats them really well, but almost shrinks down the tumors to the point where they almost disappear. So all of these things are steadily increasing marginal gains to improve our clinical outcomes. So better surgery, better systemic treatment, better surveillance in the first place, and again, expanding what we can do afterwards. So if people do get recurrence or locally advanced disease, we can offer them sort of radical surgery. And actually at Coventry, we will do exentative surgery robotically, although if it needs a big open operation, we refer them on to Birmingham. So probably that's a little bit about bowel cancer. For you guys, the challenge is that bowel cancer symptoms are basically pretty much the same as diverticular symptoms, and a high proportion of your patients will have diverticular disease. They can get colicky abdominal pains, diarrhea, constipation, and bloating, just discomfort, noticing their stool, the changing, becoming pellet-like. So it can be really difficult. We know now that in the past, if you had any symptoms of diverticular disease, we used to chop your bowel out, whereas now we actually can get away with conservative measures, with antibiotics, but we frequently see patients with acute diverticulitis, pains, and if they've got a complication such as a perforation or abscess, we now largely will use radiological drainage, but if that doesn't work, then we resort to surgery, which sadly, as an emergency, still now involves usually a resection with an end colostomy. We do try and resect the bowel and do a primary anastomosis, but even those, we probably end up giving them a defunctioning ileostomy. It's when they've got complications like fistulas, strictures, maybe it's quite straightforward, we can operate, but when they haven't, it gets more difficult. And I'm sure, I have a whole group of patients who we're umming and ahhing about whether they should have surgery, and it's still a major operation, and it's not without risks. And certainly, if you have patients you're not quite sure of what their vague symptoms are, as long as we've ruled out bowel cancer, then it still needs probably a discussion with a colorectal surgeon as to how best manage them. Or, some patients would really benefit from surgery, but it's picking out the right ones for that. Finally, I'll mention inflammatory bowel disease, which again will give you a whole host of horrible symptoms. And I guess my point for this slide is really that it's much more common than you think. There's sort of a significant proportion of classically younger people will have a diagnosis of Crohn's disease or ulcerative colitis. Ulcerative colitis is slightly more common. They may have vague symptoms. They may just have difficulties maintaining weight, and it's just being aware of these things and recognizing that they may well need referral on, and picking it up early. Frequently now they avoid surgery. Our gastroenterology colleagues have some great medications they can give and actually do a lot more with those and go for a lot further than we used to in the past. And if they do ultimately need surgery, we obviously primarily treat perianal symptoms of fistulas and things like the same, but we can offer them robotic surgery, and we've actually got a specialist IBD surgeon, Abigail Patel, who does. She's come from Oxford, having done a fellowship there, so she does complex stuff. The rest of us do the more straightforward stuff, and with my complex robotics, I can do a lot of joins internally, so they don't have lots of scars on their abdomens, which is great for sort of if they're going to need redo surgery or for further operations. So yes, there are many things we can do to offer to help, but it's really for you guys. It's being aware that there's a wide range of treatments. It's not just an operation. Mostly it's medical, and there's a broader range of medications, and even the types of medications, there's a lot greater number of ones that work differently on different patients. There we go. So the final thing, so that chap on the left standing next to me is Danilo Miskovic. So he and myself, we, due to my robotic skills, we now operate privately as well, doing robotic surgery. And we made like this on Monday. I resected someone from up here. I did an anterior resection on them for their bowel cancer in a hospital in London. But you know, I look after them at the Wellington and then in the Nuffield, and all their care afterwards with their oncology is all done under the Nuffield, which is, you know, so for their patients, they have one trip down to London, then all the rest of the follow-ups done at the Nuffield. So I'm more than happy to see patients and do major resections using care through the Nuffield, and we find the patients like really benefit from it. Similarly, we can do diverticular resections, you name it, we can do it, but or hernia repairs. But yes, hopefully that will make sense. If anyone's any questions, now's the time, as we've got about 9 minutes left. Done silence. Good. That's usually a good sign. Hello. Thumbs up. That's a good sign. So if any of you got any questions out after this at any point or something, or there's, you know, you want to discuss, you know, just message me about patient. I'm more than happy to take, even if it's someone you don't feel that wants to see me at the Nuffield, I'm more than happy to see someone at Coventry, or just I'm happy to text or, you know, have email conversations. It's fine to help. Good.
Okay, thank you. So yeah,
Good.
I think that's everything. Unless there's any questions, I have popped the link for our survey into the comments section. So if you wouldn't mind just leaving some feedback, it should only take a minute or two. I think that's everything. So thank you, Mr. Evans, for presenting for us this evening, and I'll hopefully see you all at the next lecture in June.
Thank you.
Okay.
My children didn't walk in, which is good. Brilliant. Thank you all. Nice to Okay. Thank you all for coming. I appreciate there was actually quite a nice number. So thank you very much. I appreciate that. Okay.
Thank you.
Okay.
Have a good
Thank you.
evening. Thanks.
Thank you. Bye-bye. Bye-bye.
Thank you. Bye.
Bye.